everyone. Thanks for joining another episode of ImmunoLogic, where we unpack the wild ride of immunotherapies with both scientific rigor and a healthy dose of humor, hopefully. I'm Joe Fraietta, your resident immuno-obsessive, always fueled by too much caffeine and an unshakable fascination with how our immune systems can often save the day. The other day I was browsing online and I kept seeing this acronym, TIL, and being the immunotherapy nerd I am, my brain instantly went to tumor infiltrating lymphocytes. And I was impressed and I said, wow, TIL is really trending. And then I realized, or I should say, I asked some grad students in my lab, and this isn't a new acronym, that they meant today I learned. So much for being mainstream. I'm not really mainstream anymore, too far removed from the students and not really down with the lingo. But it got me thinking, nevertheless, maybe we need more people learning about our kind of TIL. And after all, today I learned that after decades in the making, TIL therapy is finally having its big moment. And trust me, that's something worth trending. So today we're diving into the remarkable history and evolution of tumor infiltrating lymphocytes. And hopefully we're going to cover its origins decades ago to the recent FDA approval of the first TIL-based immunotherapy for melanoma. And from what I know, which is very limited, it's a story of scientific perseverance, setbacks, comebacks, and ultimate triumph, I would say. And it raises a lot of interesting questions. So to guide us through this journey, it's a pleasure to introduce Dr. Michael Lotze, who, if I may say, is a true pioneer in immunotherapy and a personal friend and hero of mine. Just in the way of introduction, Michael is a visionary physician scientist, actually a surgeon, whose career spans from the earliest days of interleukin-2 and cell therapy at the NCI to leading really cutting-edge research and patient care now at the University of Pittsburgh. So your accolades, he's currently a professor of surgery, immunology, and also bioengineering at Pitt. And he was recently honored with the Society for Immunotherapy of Cancer's Lifetime Achievement Award for his contributions to the field. And if that weren't enough, he's also my boss in a way. He's the editor-in-chief of the Journal for Immunotherapy of Cancer, where he's still challenging us with new ideas. And so across, his career that includes, again, the pioneering IL-2 trials, executing the first gene therapy protocols as well at the NCI, and mentoring, I have to say this, Michael, countless young scientists, including myself. And it's not just at Pitt, which is really remarkable to me. You're really all over the place, really providing great mentorship for hopefully the next generation of scientists. But I'll say that Dr. Lotze's name has become synonymous with innovation in cancer immunotherapy. And so, Michael, we're truly honored to have you on the show. Welcome.
Thank you so much. What a great introduction. And I'll try to bring some humor into this. We'll start off with the very beginning, where actually did the first cell therapies when I was at the NIH in the surgery branch of the NCI. And that goes back to the late 70s, early 80s, when we gave something called IL-2 activated killers or LAC cells. And we also did some of the first CAR T cell studies there, as you know.
True.
When we had Zela Gashar in our lab. And the very first growth done by a Israeli scientist, Ilana Iran, growing T cells out of mouse tumors, since we knew that they were likely there for a reason. We thought about calling them the Lotze killers for a while. We called them a variety of different names, but it ended up being TIL, and I think that's stood the test of time. I'm going to say that I just reviewed a paper for Lancet Oncology, and about half the time they use the word TIL, and half the time they use the word TILs. And I want to go online on your show saying that it is TIL, but TIL is like sheep. It's intrinsically plural as opposed to singular. So it's TIL, not TILs.
Good to know.
Tumor-infiltrating lymphocytes. It's in the definition, so just call them TIL.
Yeah, no, definitely. So what do you, in your mind, if I could just ask, and I always draw parallels, of course, the CAR T therapy, but what were the key scientific milestones and also hurdles, right, from these first awe-inspiring experimental results to the recent regulatory triumph? It's not old news. And so also I wanted to ask you on a personal note, since you have this very unique vantage point, did you ever imagine that it would take this long to see TIL therapy go from I don't know, an experimental Hail Mary to an actual licensed treatment? So I'm curious, I guess, in essence, what kept the faith alive through the years of skepticism, presumably?
So I would like to credit my former mentor, Steve Rosenberg, for absolutely persisting and keeping it on a straight line. Now, should say that the whole field of immunology, of course, has grown up over the last 40 years, but who would have thought that it would take it 40 years to go from an idea to a approved therapy for patients with melanoma? If you go back to the very beginning, we thought cell therapy was going to be necessary, and when we started, we looked like all immunologists for specificity, and we kept coming up with these lac cells. So we thought that was the answer. We published it in the New England Journal back in, I think it was 85 or so, something like that, where we showed that IL-2 plus a combination of IL-2 activated what are essentially a mixture of NK cells and T cells could mediate important anti-tumor effects. When we did the randomized prospective clinical trial comparing IL-2 to lac IL-2, there was essentially no difference. IL-2 was really what was driving all the responses in patients with melanoma and kidney cancer. Subsequently, in the early days of IL-2 therapy, we actually had people who were responding initially and then progressing, or people who didn't respond at all. And we had known by that time that we could find T cells from patients, particularly from melanoma, that were specific for the autologous tumor and could kill it at a high level or release gamma interferon. We knew that. We also knew that it wasn't just IL-2, that combinations of IL-2 plus IL-4 did it, that TIL were likely to play an important role. And we thought it was their polyclonal nature, that they were a large number of diverse T cells that really were specific for each individual patient. And so we believed in that as a way to go. So the first set of patients that we treated, and I think the first paper was maybe 88, where we took patients who had failed high-dose IL-2 and showed that if you expanded T cells from their tumor, that you could administer them in combination with IL-2, and you could see responses of up to 15, 20%. And that was at a time when we were culturing T cells, not for, as we currently do, for 3 weeks, but over a period of months, 1 month, 2 months, 3 months. And it became increasingly clear that the patients who did the best were those who were in culture the shortest time. And so you asked, what was it that made a difference? I think there were 4 major breakthroughs in TIL therapy over the years that made it possible. And I could go through those if you'd like.
Yes, absolutely.
Okay. So the first one was the insight that so-called young TIL, meaning they'll have a lot, very long in culture, and it's very much in parallel, as you say, with CAR T, where we know that the young CAR Ts in culture short periods do as well, if not better, than those longer in culture. And so we, with the help of Mark Dudley, who'd come out of Stan Riddell and Phil Greenberg's lab, did something called the Rapid Expansion Protocol, where at the end of a couple of weeks, we could rapidly expand cells by using mitogenic OKT3 antibody, along with irradiated either autologous or allogeneic feeders. And that allowed us to get a therapy initially down to about a month of culture. When I was at Iovance years later, we got it down to 22 days. Current strategies, just looking ahead, while I was at another company at Nurix, we were able to get it down to 16 days. And so it's moving in the same direction as CAR Ts. The second great advance, also developed by Mark Dudley, was to introduce a quiescent culture as opposed to shakers or roller bottles with bottom respiring flasks, also known as Wilson-Wolf flasks or G-Rex flasks, that allowed us to put cells in culture and grow them over an extended period without a lot of tech time or disturbances. That decreases your opportunity to introduce variation, bacteria, you name it.
Sure.
I think that was a real advance. The third advance was we had started as a source of tumor about a 1 to 2 centimeter fragment of tumor that we would digest with collagenase, DNase, and hyaluronidase to get a single cell suspension. And what we learned was that using small fragments of tumor, 2 to 3 millimeters, was a better way. And I think of it that we were actually ripping T cells out of the tumor with digestion, killing many of them in the process. Let the T cells come out in high concentrations of IL-2. And then the fourth and final major advance that I think brought us into the modern era, that's the last 10 to 15 years, was the ability to do something that we stole from the hematologist, which is non-myeloablative chemotherapy to prepare the host to receive the cells, so that you had homeostatic proliferation with homeostatic cytokines being produced. You had elimination nominally of suppressor cells. You created room for engraftment and expansion. And a Lotzism, you also got rid of those pesky neutrophils that appeared to inhibit some aspects of T cell functionality. And so it was those four factors that really made TIL come alive. My job when I was at Iovance, and this goes back 10 years ago, was to take an incredibly cumbersome, difficult process that took an awful lot of tech time and try to industrialize it. And I think it was the same thing that, who was it, Novartis did with your protocols, and took what was an academic exercise and made it possible to do at scale. And that's essentially what we did. It took another 10 years for Iovance to get past the FDA, for whom this was a difficult product to approve. And the reason is each person's product was different from the other person's. It was a mixture of T cells cultured maybe in a common way, but they were held up for getting approval for 2 years with so-called potency assay. How do you know that what you're calling your drug is your drug? And it's not so much to show that your therapy is going to work, just like aspirin is aspirin is aspirin, independent of whether it makes your headache go away.
Right.
The potency assay was to say when you change media sources or you change cytokine sources, or as you know very well, when you move from just straight IL-2 to IL-7 and IL-15, you can see very dramatic differences. Even though your preclinical data says it's got to be better, all of a sudden you realize that it may not be better because it's what it does in the patient. So how do you know what it is? And so luckily Iovance was able to work through with the FDA that promise.
Yeah, absolutely. And so that's what I was thinking, maybe well, you talked about the technological improvements, but
right.
I thought as sort of a fifth point that maybe the FDA itself became more receptive to cell therapies in solid tumors. So do you think, just drilling down to the clinical context, that, for example, melanoma patients, right, who failed checkpoint inhibitors needed new options, and that in essence created an opening for TIL, or not really?
So the advances in melanoma, if you think about it, the advances from 40 years ago were two cytokine therapies, alpha interferon and IL-2. Alpha interferon was approved for adjuvant therapy of patients with melanoma, and IL-2 was approved for patients with advanced metastatic. But then we had a long dearth until we finally realized that distal to RAS signaling was a mutant BRAF molecule with often V600E mutation that allowed the development of chemotherapeutics targeting what was an oncogenic mutation in BRAF and melanoma. And the thing that drives me crazy is how long it took the people to realize that they just looked one step downstream of the RAS signaling pathway. Here, there was something that was out in the open in about a third of patients with melanoma that you could easily target.
Right.
So that was the big advance for a while. But you're right. Once you shot through your BRAF, if you could respond, there was, or IL-2, there was really nothing else for you. And so TIL did fill an opening. Now, you should recognize that prior to checkpoints, immune checkpoint blockade, the response rate, given the 4 advances I mentioned with TIL, the response rate was as high as 56%, with 25% of all patients treated having complete responses that were extraordinarily durable, went on for 10, 15 years with, say, 1 out of 25 progressing and having their tumor come back. I don't know if you want to call that a cure, but it's as good a thing as you can imagine. So, to flip it, to play off your experience with CAR Ts, as you well know, there's a very high response rate with CAR Ts, but many of the patients progress for a whole variety of reasons. Part of it is because the tumors just say, okay, I don't need CD19 anymore, or they mutate out the epitope. But it's enough that it happens that it says going after single targets has some risks associated with it. And we see the same thing with single TCRs when they're put in to cells. And so the great advantage of TIL is that you have a broad repertoire of associated cells. And if you think about it, we're all mesmerized by living in the era of monoclonal antibodies, monoclonal CAR T cells, and monoclonal T cells. But in actual fact, that's not how the biology works. Every scientist knows that no matter how good your monoclonal is, a really good high-titered polyclonal antisera is always better. And I would venture to say the same thing is true for T cells. Because if you think about it, T cells are a weak, puny, pathetic cell with only a 10 minus fifth molar affinity for their targets compared to 10 to the minus ninth molar affinity for a good antibody, or even more, and so it's what one of the mathematicians, John Newman, called a single, non-specific or poorly unreliable component. When you had hundreds or thousands of them, you could get a reliable machine out of it. And so the promise of TIL was also realized, although perhaps less formally, in a variety of other tumor types, including cervical cancer, head and neck cancer, and now we see breast cancer, lung cancer, colorectal cancer, cholangiocarcinoma, but at less frequency. I should circle back to melanoma, though, before we move on, and say that in the post-checkpoint era, it appears that there was only a more limited response, which is what Iovance had to show was sufficient for getting approval, which was around a 25 to 35% response post-checkpoint. And when you look carefully back, are there any therapies, whether they be BRAF inhibitors, alpha interferon, IL-2, checkpoints, you name it, were there any therapies that would predict that you had a better response to subsequent TIL? And there was only one therapy that was associated with better outcome. Do you know what it was?
IL-2?
IL-2, exactly. As my nickname was one more dose Lotze, I always believed that IL-2, you could just get enough in. Interestingly enough, the patients who have prior gotten checkpoints appear to do worse with TIL. And the question is it because you've already subtracted out patients who were the most responsive to immunotherapy, or have you truly changed the biology? And I think the feeling is now, with soft data, is that it's probably a combination of both. It's probably a combination.
Fascinating. But since you mentioned it, do you really see TIL therapy? I mean, I'm a believer, let me just put that out there, but expanding to other solid tumors in the near future, or is melanoma just the low-hanging fruit because, of its high mutation burden and relatively, let me say relatively, immune-friendly microenvironment compared to some other indications? So can we crack this to make TILs work in colder tumors too?
So I oftentimes joke around and say anybody can shake a melanoma and the T cells just fall out. I mean, it is a T cell rich disease in most individuals, and it's in part what you related to is it's a high mutational burden with a high TMB and lots of hits on goal and a lot of CD8s. Interestingly, the real challenging solid tumors, epithelial tumors, lung, colon, breast, pancreas, prostate, etc., are infiltrated with T cells, all of them to one or more degree, but they're mainly the ones you grow out are CD4s, the predominant cell types. And the literature is rife now with data showing that you don't need CD8s necessarily. You can even have class 1 diminished tumors and still see responses either to resident CD4s or, as you know, gamma delta T cells, which are largely understudied. I should put in a cautionary note. There have been, during the biotech winter that we're in, 18 companies launched trying to get TIL therapies to the market. And many of them are either struggling or have shut down their TIL programs. But I think you see that on the same side of the street on CAR Ts, that many of the people have moved out of CAR Ts for cancer and are moving into autoimmunity or getting out of the business altogether. So I think it reflects more the current economic climate rather than the opportunities that exist for TIL.
Absolutely. So now I wanted to shift gears a bit and talk about new ideas on the horizon, and specifically your new hypothesis. So in the midst of all of this progress with manufacturing and approving TILs, you've been cooking up a hypothesis that's about to be published in JITC, and I'm an associate editor there. So I get to peek at the articles before they come out, even the editor's articles.
So anybody can get it now.
If I'm allowed to say this, so from what I've read, you and Neil Carlton propose a reciprocal learning model in which please correct me if I don't get this right, but normal epithelial cells and resident immune cells engage in lifelong crosstalk, right? Very intriguing. Through damp signals, antigen presentation. What else did you mention? Cytokine exchanges. But what's really intriguing about that is that trains both sides long before you claim any, or think, or theorize, I should say, any malignancy emerges. And then you break this into the 3 stages of inflammation, initiation, and inception. So just for our viewers, I should say, can you maybe just summarize how disruption at any of these stages? So say chronic inflammation, or if you have, I don't know, hormonal imbalances, right? How might that tip learning toward a maladaptive state, and pave the way for immune escape? It's really an intriguing hypothesis. I love it.
Thank you. Thank you. I'm glad you enjoy it, and I want to socialize it a little bit. Thank you for using your podcast to do it. So let me bring it back up to a 30,000-foot view. One of our colleagues is a guy at WashU, Bob Schreiber, who, let's say 25 years ago, said that cancers arose in the setting of three different immune editing steps, which are called the three E's. And the first one was elimination. A tumor comes up and it's killed and eliminated. But because you don't kill all of them, it's all a stochastic, random, at some level, statistical event in terms of a T cell coming in contact. He said that you go into a phase over a period of months or years that he called equilibrium. And then we don't even see an epithelial tumor in particular until 7 to 10 years after the very initiating event associated with a driver mutation that said, I'm going to grow up to be a real cancer when I grow up. And that was called escape. And so the strange thing is that since we're all attuned to cancers showing up suddenly, we think, that's when the immune response initiated. And in actual fact, we push it back even further through the three I's. And this allows us to say that I comes before E, except after C, meaning cancer. And that's inflammation, initiation, and inception. And so the notion is that epithelia, which are the major problems that oncologists have to deal with, epithelial tumors. Epithelia have three functional roles. One is barrier function. Keep the bacteria in your gut on one side and keep blood and nutrients on the other side. Or oxygen on one side, CO2 on the other. But the other is to get exchange. So nutrients can go from the gut lumen into the blood, but then materials, waste products can go the other way, both in the gut, in the liver, in the kidney, and so on. Or oxygen one way in the lung and CO2 in the other. And the third thing that it has to do is that because of this diametrically opposed functionality, one is barrier. And if that's all you had to do, you could have lead plate at every epithelium. You could be like an aardvark everywhere with lead plate. But because you have to do selective transport, many of the epithelia are only 1 or 2 cell layers thick. And as a consequence, they are amenable to disruption easily. Right. And in order to keep an eye on it, our theory is that 550 million years ago, when we first developed an adaptive immune response, we invented T cells and B cells, not so much to keep an eye on viruses and bacteria, but to keep an eye on our epithelium to make sure that in the conveyor belt that they were not mutating or changing to then disrupt the epithelium and let the bad guys in or let the good guys out. And so there's a notion that T cells in particular are trained not on thymic fibroblasts, not on thymic macrophages, not on thymic endothelium, but rather thymic epithelium. And I don't think that's an accident. I think actually we had a preceding 3 billion or 3.5 billion years where our innate immune responses take care of most of the viruses and bacteria pretty well. It's nice to have the adaptive immune response, but it's great window dressing, primarily to reinforce our epithelial barriers. And so if you look at the major cancer types that we have, the common onlog, whether it be smoking for lung cancer, bladder cancer, or prostate cancer, is inflammation, or hepatitis in the liver, inflammation, or pancreatitis in the pancreas, or H. pylori in the stomach. The beginning of cancer is often in the setting of chronic inflammation. And we think that's the beginning where you have more rapid epithelial turnover, and the immune epithelial interaction is where the learning goes on. So just think about it in the human breast. Just think what the breast does. once a woman starts menarche with their periods, every month they go through a rapid expansion of breast epithelium. And then if they're not pregnant, they kill them all off at the end of a month. And most of the cells that undergo apoptosis are eaten by tissue resident macrophages, but some of them are not. They escape and they release stamps like HMGB1 or DNA or other things that incite an immune response. And basically, what happens is that the immune response learns in the process of keeping an eye on the breast, but the breast epithelia, just as we've learned from skin carcinogenesis and skin epithelium, also learns about what the immune response is paying attention to. And it's this reciprocal learning between the two sites that we think allows, you say it's a tragedy that 1 in 8 women will get breast cancer in their life, but it's actually a big win for a long-lived species like ours. The 7 out of 8 women, in spite of this cyclical growing, dying, growing, dying, growing, dying, never get breast cancer. And this says how effective the immune system is in keeping an eye on epithelium. And there's one other important message that I'd like to convey to you and your audience, which is that one of the major goals of the adaptive immune response is not to respond, it's to tolerize. It's to
So true.
tolerize. And as we develop mutations, as every cell type does in our body, as we grow up and as we get old, we end up with accumulated mutations, most of which don't make a difference. And the immune system knows that somehow. And so you get tolerized. And so one hypothesis lurking in the background of my head is this idea, because if you look at the repertoire and the shape of the repertoire, it steadily goes down with age. And I think what you're doing is driving apoptotic death of T cells where they say, oh, you recognized a mutation in the context of an MHC class 1 molecule, or gamma delta is something else that we don't know. And it doesn't matter. You just go ahead and die in apoptosis. And I think that's one of the explanations for the loss of repertoire. But I also think if you look at people who have cancer, whether it be kidney cancer, pancreas cancer, head and neck cancer, and you look at age and sex max individuals for the size of the repertoire measured by diversity, it's lower in patients with cancer than it is in those who are age and sex matched. And either that's because people with less of a repertoire, less diversity, get more cancer, or that the cancer has, in the process of genomic instability, generated mutations that allow you to shrink your repertoire even faster than normal aging would do. So that's a corollary of the hypothesis that wasn't so much in that paper.
So elegant, yeah. Let's step back a bit, Michael. So you've been at this for over 3 decades, I guess 4 decades, right? Close to 4, from the early cytokine days through, I don't know, the vaccine era to today's, cell therapy renaissance. It's a renaissance, right, in many ways. You've seen hype and disappointment, but also unprecedented successes. So I'm curious, what has this journey, I don't know, taught you on a philosophical level? So, for example, the fact that something like TIL therapy, which was considered too fringe, probably, right, for a long time, for years, is now a validated therapy. Does it make you more of an optimist that perseverance in science pays off, or a realist, flip side of the coin, just in terms of how much work it actually takes to translate a great idea into a viable treatment? Just maybe you could share your perspective a little bit.
It's a really good question, Joe. So thank you.
Putting you on the spot.
I think, like every good interlocutor, you actually gave me the answer in the process of asking the question. So it was very kind of you. But it's just persistence. But I do think that one of the things that is quite critical is that we were learning the rules of the game while we were playing it. In other words, we learned so much. When I started, we had only a dim sense of what cancer was all about. P53 had not been identified, RB had not been identified, RAS had not been identified, HER2/neu, any of the driver oncogenes that we now know are critically important for driving carcinogenesis. In the same way, when I started, we had only the vaguest sense of what the T cell receptor was. And so the ability to jump into a complex, admittedly complex field and do genetics and biology and try to discern some of the basic rules along the way, in many ways, being persistent allowed us to reveal and unpeel. I don't know if you know those Russian dolls, the matryoshkas. Every time you take one head off, you find another doll inside. And that's the
Right.
way my career has felt to me, is that just when you think you really understand something, you say, oh my God, there's another doll inside. And there's more for us to learn. Back when we started identifying oncogenes, we defined them as genes that generally either made cells grow faster or die slower. But it was very much in an earlier, more innocent era where we didn't know about how critically important the host response was in the dialogue with an emergent cancer cell. And so we now have data, which is quite clear that if you look and say in melanoma patients, which we talked about extensively, that what are the tumors that don't have T cells in them? There's some of the drivers. Wnt beta-catenin is associated with T cell deserts. But if you block it, Wnt beta-catenin signaling, the T cells come back in. Same thing with P38, which is a driver for a lot of tumors. If you block it, as Jason Luca has shown, you enhance T cell response. Recently, we have pan-KRAS inhibitors, where when you block it, you get T cells coming in. And if you don't have T cells, you don't see responses. In other words, they're absolutely critical. And the same thing is true with HER2, same thing is true with BRAF inhibitors. And so I think we're in an era now where we can say our earlier fumbling attempts to understand the complex biology of cancer, where we focus solely on the cancer cell, needs to be rewritten and say that instead of defining oncogenes strictly in the context of the cancer cell, we should say that one of the criteria, and call them now immuno-oncogenes, is say they also have to suppress immunity because of those earliest events that we hypothesize go on with the interaction between the epithelia and immunity. And I'm going to look hard now to see if I can find examples of driver mutations that are not associated once you block them or correct them with gene therapy, that are not associated with immunosuppression. Maybe it's generalizable now.
Absolutely. So thanks, Michael, for sharing not just your expertise, but also your wisdom and perspective, and really hearing the real stories behind these therapies, behind TIL therapy in particular. The struggles, the doubt, the eureka moments is really incredibly valuable. So that's it for today's episode of ImmunoLogic. Remember, every breakthrough is built on collaboration and perseverance. That really came through in today's episode. So please stay curious, keep challenging the status quo, and we'll catch you next time as we continue navigating the exciting frontiers of immunotherapy.